All right, let's dive into one of the most high-yield topics in both anatomy and emergency medicine, the body's limb compartments. We're going to take a tour of these hidden anatomical rooms and then talk about the absolute emergency that happens when the pressure inside them gets too high. If you're a med student, this is need-to-know stuff, so let's get right into it.
So think about this for a second. What on earth could connect a massive traumatic crush injury to something that seems so simple, like a cast that's just a little too tight? Well, the answer is the key to this whole discussion. Dangerously high pressure building up in a space that can't expand. And that right there is the heart of the problem in acute compartment syndrome.
So here's our roadmap for today. First, we'll talk about what these hidden rooms actually are. Then we'll go on a quick tour of the major compartments in your arms and legs. After that, we dive into the pathology, what actually goes wrong when that pressure builds, how you spot this emergency, and finally, what you need to do when you're racing against the clock to save a limb. You know, our limbs aren't just a jumble of muscles and nerves. They're actually super organized. Imagine all your muscles, nerves, and blood vessels being neatly bundled together into these sealed-off units. The wrapping around them is this incredibly tough, leathery stuff called deep fascia, and it's great for making movement efficient, but it creates one huge problem. It doesn't stretch, so if there's any swelling, there's nowhere for it to go.
Okay, let's kick off our tour in the upper limb. And I want you to remember, knowing this anatomy isn't just about passing an exam. It's absolutely essential for figuring out injuries and knowing what's going on in surgery.
What's really cool about the arm is just how simple it is. It's basically split right down the middle into two spaces. You've got the anterior compartment up front. That's your flexors, like the biceps and brachialis, and it's all run by the muscular cutaneous nerve. Then in the back, you have the posterior compartment. That's home to the triceps, your big elbow extensor, and it's all powered by the radial nerve. It's that simple. Flexors in the front, extensors in the back. Done.
But then you get to the forearm, and things get a little more crowded. The anterior or volar compartment is the command center for flexing your wrist and fingers. It's even organized into 3 different layers: superficial, intermediate, and deep. The big takeaway here? The median nerve is the main player for almost this entire group, with the ulnar nerve helping out on the pinky side. Now let's flip it over to the back. This is the dorsal, or posterior compartment. Its job is the exact opposite, extending your wrist and fingers. And if there's one nerve you need to connect with this whole group, it's the radial nerve. Specifically, it's the deep branch called the posterior interosseous nerve, or PIN for short. Oh, and we can't forget this little special group on the side of the forearm. It's called the mobile wad of Henry. It's these 3 muscles that mainly work on the wrist. The key thing to remember is that even though they sit in a unique spot, they are all innervated by the radial nerve right before it splits. All right, let's head down to the lower limb. Now, these compartments are built tough. They have to be, for walking and bearing all our weight. And that means their fascia walls are even more rigid and unyielding than the ones in the arm. The thigh is beautifully organized into 3 distinct groups. Up front, you've got the anterior compartment, which extends the knee, all powered by the femoral nerve. Then you have the medial compartment, which brings your leg in. That's adduction. And that's the job of the obturator nerve. And finally, in the back, you have the posterior compartment, your hamstrings, which flex the knee, driven by the sciatic nerve. Moving down into the leg below the knee, things get a little more complex with 4 compartments. The anterior compartment is responsible for dorsiflexion, that's pulling your foot up towards your shin, and its nerve is the deep peroneal nerve. Then the lateral compartment handles eversion, or turning your foot outwards, and that's run by the superficial peroneal nerve. And here's a huge clinical point. That anterior compartment, it is by far the most common place to get compartment syndrome. And finally, we get to the back of the leg, which is split into 2 posterior compartments. The superficial one has those big calf muscles you can see, the gastrocnemius and soleus, and then tucked away underneath is the deep compartment. But they pretty much work as a team to plantar flex, that's pointing your foot down like a ballerina. And they're both innervated by the tibial nerve. Okay, we've finished the tour, we've seen all the rooms. Now we get to the really critical part. What happens when something goes wrong and the pressure inside one of these sealed rooms starts to climb and climb and climb? This is where we talk about a true surgical emergency. So compartment syndrome is this absolutely vicious cycle. It all starts with some swelling or bleeding inside one of those fascial compartments. But remember, the fascia can't stretch, so the pressure inside just skyrockets. It gets so high that it starts to squeeze the blood vessels shut. First the veins, then the arteries.
Blood can't get in, so the muscles and nerves inside start to starve for oxygen. That's ischemia. And if it's not fixed, they start to die. That's necrosis.
So what can set off this horrible cascade? Well, the number one cause, the classic one you'll always hear about, is a tibial shaft fracture. But it's not just big-time trauma. Crush injuries, severe burns, even the swelling that happens after blood flow is restored to a limb can do it. And this is so important. We can cause it too. A cast or a dressing that's put on too tight is a major, major risk factor.
And that brings us to maybe the single most important skill you need to have: how to spot it. Because in this situation, just suspecting it is half the battle. Your clinical judgment is the most powerful tool you have, because catching it early is the only way to save that limb.
Okay, everyone learns the classic 6 Ps, but you have to know which ones matter most. The earliest, loudest, most important alarm bell is pain. And it's not just any pain. It's pain that is totally out of proportion to what you'd expect from the injury. The key exam finding is excruciating pain when you passively stretch the muscles in that compartment. Paresthesia, that pins the needles feeling, also shows up early. The other Ps, pallor, poikilothermia, paralysis, and especially pulselessness, those are disastrously late signs. If you wait until the pulse is gone, you've waited way too long. Now, while your diagnosis is mostly going to be based on what you see and hear from the patient, you can actually confirm it by sticking a needle in there and measuring the pressure. And here is the number you need to burn into your brain. Anything over 30 millimeters of mercury is a massive red flag. That tells you the tissue is not getting enough blood and you need to do something now. So you've got a high suspicion. What now? Well, now you are in a flat-out race against time. With every minute that ticks by, more muscle and nerve tissue is dying. Your actions have to be fast and they have to be right. The first things you do can happen right there at the bedside. You have to get rid of anything that's squeezing the limb. Cut the cast off, all the way down to the skin. Take off splints, unwrap dressings, get it all off. And here's a super important point. Keep the limb at the level of the heart. Don't elevate it. I know it feels natural to prop a swollen limb up, but in this case, it can actually make things worse by making it harder for blood to get in. While you're doing all this, you are on the phone getting an urgent surgical consult. Because there's no pill for this. The only thing that truly fixes the problem is surgery. It's called an emergency fasciotomy. A surgeon goes in and makes long cuts through the skin, and, more importantly, through that tough fascia of every single affected compartment. It's the only way to relieve that crushing pressure and let blood flow back into those starving tissues. This is not optional. And why are we so frantic about this? Because if you delay, the consequences are absolutely devastating. We're talking about muscle dying and never coming back, permanent nerve damage that leaves you with a limb that doesn't work right, a horrible claw-like deformity called a contracture, even kidney failure from all the dead muscle breaking down. And in the worst case, you lose the limb, amputation. So let's end on a real-world scenario. You have a patient with a broken tibia. You've given them morphine, but they are still screaming in agony. What is your very first move? You don't wait for another dose of pain meds. You don't wait for an x-ray. You immediately suspect compartment syndrome. You grab the cast cutters and you call the surgeon. Trust that clinical gut feeling. It saves limbs.